Hello, welcome to Sign Out with the Professor. 50 minutes of surgical pathology fun involving both the routine and sometimes the extraordinary. We'll be beginning our program momentarily. So thank you so much for joining us for this session. I've prepared a number of cases with kind of interesting differentials, I think. And did you have a chance to look at the slides beforehand?
Sorry.
Okay.
Unfortunately.
Well, the link for the slides, of course, will be available, and you can look at them. So this first case is a 17-year-old boy who was developing some leg pain. It was kind of vague and so forth, not really sharp or serious, but it seemed to be getting a little bit worse over time. And ultimately, he had a radiograph which showed a lytic lesion that was slightly expanding the cortex in his tibia. And so that ultimately led to them doing this curettage sample, which you can see here has come out in fragments. And at low magnification, I think the thing that stands out to me is we see a number of kind of cystic spaces. We also see some, what looks like maybe bone formation of different types and this loose tissue, as well as a couple of areas of more cellular tissue. So these are all the features we'll need to sort of take into account as we look at this sample. So we'll go look first here at these cystic areas and see kind of what the lining tissue is. It kind of is a loose tissue. It doesn't look like there's really a specific endothelium necessarily. We see a few stellate cells here and some giant cells in this sort of loose tissue here, and a little bit more fibroblastic or collagenous tissue further out. I'm going to turn on the captioning so that you can, if you have difficulty, let's see, where is it? Live transcript, there we are. Enable you to see what I say. So looking a little further here, we can see that this bony tissue that's being formed is new bone. It's not mature lamellar tissue. It's coming out of this tissue, but it's not particularly atypical. The stroma around it here is, got a few giant cells, but it's fairly bland. So it doesn't look particularly like, osteosarcoma per se, which, we always are concerned about in young adults, but some of these cells are a little bit on the osteoblastic side, I suppose, sort of larger cells. And then we'll look at these areas of increased cellularity, which we have down here. And we can see here, there's again this sort of cystic change, a little hemorrhagic material, and some more giant cells and a little bit more cellularity. So kind of the same story with this sort of cystic lining type of a pattern with central hemorrhage and then the bone surrounding that. So in a lesion like this, it sort of looks like it's benign or low grade. It would always be important to look at the radiograph. And as we look at this patient's radiograph, we can see that, as we suspected, it has a very benign appearance. It has a very low-grade margin. It's not infiltrative. There's a little rim of increased calcification at the edges. And you can see it's sort of a little bit loculated. There's sort of a little bit of trabeculation to it. So I think the differential we are considering will be things like unicameral cyst, but this looks like it has more than one locule, and an aneurysmal bone cyst, which is what this is. But aneurysmal bone cysts, which expand the cortex and are lytic like this, can be of two types. You can have either a primary type or a secondary type that is secondary to another lesion, like a giant cell tumor or fibrous dysplasia or something like that. And so sometimes if there's confusion, we may need to resort to some additional testing. And recently, we've become aware that aneurysmal bone cysts, the primary sort, are almost always associated with some sort of a fusion gene rearrangement involving the USP6 gene. And it has a variety of pairing partners that it can have as well. Also, in this differential, if we're thinking about giant cell tumor, there is an immunohistochemical stain that can be available in some locations. We don't have it in our lab yet, called H3G34W, that can also be used to differentiate giant cell tumor. Now, these lesions are typical in skeletally immature people. As you see, the epiphyses are not yet fused in this patient. And typically, so presents in this second decade of life. It's said that they have a risk of local recurrence. My suspicion is that many times that's related to the secondary types more than the primary types, but I don't think I have enough experience with that to gauge that for sure. So we'll go on to a second case, which is somewhat similar in terms of the radiologic presentation and somewhat of the histology, but because it also is lytic and somewhat expansile and occurs in about the same location. This was I believe, a 30-year-old patient who had an incidentally discovered lesion in the pelvis, in the ilium, on the iliac crest. And we see here a slightly different appearance to this tissue. It's got some blue areas, some pink areas, maybe some bone formation, not really completely clear at low magnification. And it's coming out in chunks, kind of large pieces. And as we look at this on higher magnification, we can see that there's a delicate vasculature here in some respects. You can see quite a number of what look like small vessels. And then there's this sort of myxoid background. And some of these cells have a little bit of a stellate appearance, you can see. Again, they're quite low grade. So this is a tumor with a myxoid low-grade appearance. And the radiograph also affirmed that for us, that this was a low-grade lesion. And looking around, it sort of has some fibrous character to it in some areas. And if you'll believe me, I think we also see in some areas, if you can find it here, a little bit more almost chondroid-like differentiation. So we'll look right here. I think you can begin to appreciate that some of these cells in this myxoid tissue are sort of within a little lacunar-like space. So it's slightly chondroid. It's not really full-blown, but it has a little bit of that characteristic to it, as you can see here. This sort of pinkish matrix with cells within little lacunae like this. So this is an example of chondromyxoid fibroma, and I'll show you the radiograph from this patient here as well. As you can see here in the pelvis, you can see it's again, it has a very sharply demarcated margin, sclerosis around it. This is not an aggressive lesion, and it has a bit of a scalloping nature to it, which is often what we see and sometimes in chondroid lesions. And in terms of histology, it is how its name sounds. It has chondroid areas, it has myxoid areas, and it has fibrous areas. So a chondromyxoid fibroma. which is a nice term for it. This is a very indolent tumor. And in terms of molecular genetics and so forth, it's been found that the GRM1 gene tends to be upregulated in these lesions. Now, interestingly, this is also a lesion that tends to occur, in the metaphysis, and this may develop sort of aneurysmal bone cyst-like areas. So this is one of those lesions where you get a secondary aneurysmal bone cyst. Here's the MRI, which shows again this sort of fluid-rich or sort of abundant loose myxoid tissue characteristic of these lesions. I had to take this from a website and so forth. It's not from our patient per se. But it does not have fat in it. It's not normal fatty marrow, where you can see here the marrow changes are more fatty. This has more fluid and tissue density. Okay, well, let's go on to case number 3, which is somewhat similar in some respects, but a little bit different. This is a patient who was 30 years old and had this lesion kind of incidentally discovered. Had an injury for another reason, an x-ray was taken, and they said, hey, what's that? This was located in the diaphysis of the tibia. So again, we're in the lower extremity, like the ABC. And here we can see some lamellar bone, kind of characteristic cortical pattern bone. And then we have this fibrous tissue, which has areas of sort of hypocellularity, and then these little nested areas that are sort of serpiginous and angulated in various ways. So looking at this on higher magnification, you might wonder, well, are these vessels? Because it kind of looks a little bit like those stellate vessels we just had in the chondromyxoid fibroma. But we don't see necessarily lumina associated with this. And some of them are fairly solid, like this triangular one here. So they look actually somewhat epithelial. So in a 30-year-old, you're not thinking about metastatic carcinoma per se. It does happen, but not usually as frequently as in other things. And so this is a situation where the location is very helpful. And this histology with a sort of biphasic tumor is very consistent with an adamantinoma. As we look at the radiograph of this lesion, here on the AP view, it's barely visible, just a very slight lucency here in the diaphysis, the proximal diaphysis. Let me see if I put in the lateral view as well. I believe I did. Yeah, so here's the lateral view. And then on this, obviously, you can see that you have cortical thickening and you have these little lucent areas here. So this is the classic location for an adamantinoma, the proximal diaphysis of the tibia. But interestingly, this lesion is quite distinctive in some circumstances in terms of its behavior. We don't usually see it in other bones, but it can occur in other bones. But it can do strange things, like it can occur both in the tibia and the fibula at the same time, and so forth. So it's really quite an interesting and distinctive lesion, not usually a life-threatening one, of course. But in an older patient, if it's discovered, of course, you'd have the differential of metastatic carcinoma and so forth. These epithelial cells that we pointed out are cytokeratin positive, EMA positive, also usually positive with P63, a squamous marker, as well. And the differential usually would include, cortical fibrous defect, osteofibrous dysplasia, and possibly even Ewing sarcoma can have sort of this expansile infiltrative pattern in some respects as well. So that raises the ante and certainly makes it valuable to biopsy this lesion. This could be something where if they can get enough soft tissue, that frozen section might be requested to evaluate whether or not you're dealing with, a more serious malignancy like Ewing's, or something more like adamantinoma that might be locally managed in a single procedure. Okay, well, let's go on to another entity. This was a soft tissue lesion. It was, it's important to know that because we see in this lesion, there are areas of bone formation. So this was separate from any bone, and that helps us to define this lesion as being not a primarily bone-derived lesion. What we see here is actually somewhat similar to what we've seen with some of the previous cases, especially the aneurysmal bone cyst. We've got some sort of loose fibromyxoid tissue. We've got a little bit more cellular tissue. We've got some reactive woven bone tissue, and some degree of cellularity here in some of these tissues. Now, is this reactive bone? Can I convince you that? Well, it's certainly woven bone. We're not developing, much in the way of cartilaginous differentiation here. And it's just coming out of the background fibrous tissue. It's difficult to perceive here, but there is a degree of how you might say zonation. There are areas that are ossified. There are areas that are more just loose fibromyxoid tissue. Here you can see some of that kind of tissue. So what are the sorts of things that we might think of with this? Well, you might think about nodular fasciitis, except that doesn't usually ossify. You should certainly think about myositis ossificans, as we may have noted. I don't know if we did note it at the low magnification. I think there was a little touch of skeletal muscle here, as you can see. So it's extending into and involving a little bit of the skeletal muscle. This was from the anterior thigh, so it's an area that's prone to traumatic injury and so forth. So with that finding involving the muscle, a degree of cellularity and some ossification, the diagnosis that seems most plausible in this situation would be myositis ossificans. And here you can see some of that peripheral ossification. Now, this is a lesion that evolves over time and has different stages. So as it becomes more mature, has been there longer, this ossifying component is at the periphery, and it's more prominent and more well-developed. At an earlier stage, you may just have this loose fibromyxoid tissue with relatively little ossification. Typically, the history on these cases is that there's some recent history of trauma, usually 4 to 6 weeks earlier, some sort of a blow or an accident or something of that sort that preceded this lesion. The other interesting feature about this, and part of the reason I included this case, is that this is also a lesion that very often is associated with USP6 fusion gene abnormalities. So it's a benign lesion, certainly not something that's going to metastasize or usually even recur, but it does have this molecular genetic anomaly that it shares with aneurysmal bone cyst. There are also some lesions that are somewhat similar that occur in the more distal digits that can also have this USP6 rearrangement. The differential diagnosis usually is with malignancy, but with the very low-grade cytology and the zonation, we're not usually going to be thinking about, soft tissue osteosarcoma or extraosseous osteosarcoma or something like that. So those are a couple of cases that I thought were an interesting differential of kind of mixture of biphasic tumors with bone and myxoid areas and spindle cell areas as well. So we'll go on to the next case. And of course, as always, you can type your questions into the chat as we go along, and we can discuss that at the end. So this is a lesion that was a man who had an expansile sacral mass. It appeared to be arising from the spinal canal, but sometimes that can be a little bit difficult. But the neurosurgeon seemed to indicate that they were within the meninges here. And as we look at this lesion, we can see, an interesting array of tissues. There's sort of this central myxoid tissue, and then a peripheral degree of, maybe epithelial or epithelioid type cells around the periphery. Not all of these little spaces have a vessel. Some do, as you can see here, and sometimes these are a little bit hemorrhagic, but not all of them have a vascular core. Cytologically, as we look at this lesion, you can see that the cytology is fairly low grade, a little bit of pleomorphism, but not much in that direction. And so this is a very interesting lesion. It's not an area where I usually spend very much of my time. So I actually had to borrow this from one of my neurosurgical colleagues who had saved the case. But this is an example of a myxopapillary ependymoma. It is, as you say, you've got the myxoid tissue and the cores, and it's got a very papillary architecture. And cytologically, phenotypically, it's an ependymal tumor. Because these cells will be positive with GFAP and negative with cytokeratins. So it's not an epithelial-derived tumor. It's certainly a neuroepithelial lesion. Originally, or earlier on, this was classified as a grade 1, WHO grade 1, but has recently been revised to indicate that these are more of a grade 2 tumor. I'm not familiar with all of the ins and outs of those decisions and so forth, but just by virtue of the histology, that's the grading that is assigned to this lesion. Now, I present it here not so much to encourage you to become neuropathologists, but because this is a lesion that is in the differential for the next lesion that I'm going to discuss. In terms of presentation, though, before we get there, this usually presents as a mass, maybe with some expansion. It may bleed, there may occasionally be bleeding into the CNS and so forth, and that could cause some pain and headache and so forth. But usually it's more the mass lesion, the expansile lesion that produces kind of an achy pelvic or lower back pain. So this is the lesion that we want to contrast this with, which also can occur in the sacrum. And has a very myxoid appearance. As you can see, there's a lot of pale tissue here, and maybe even some degree of, papillarity to some areas of this, or at least nodularity. As you can see here, it is involving or expanding through the bone. And as we look at this tissue, you can see that it's not making the classic papillary structures that we saw on the myxopapillary ependymoma, but it does have this very myxoid stroma associated with it. And as you've probably surmised here, the diagnosis is that of a chordoma. You can see that we have these cords of cells that are linked to one another in general, And many of them have a sort of bubbly or phyzoliferous cytoplasm, soap-like cytoplasm, as it's called, with these cystic spaces, multilocular spaces within the cytoplasm of many of these cells. And this is kind of classically included in the differential with myxopapillary ependymoma based on this site. These are the two most frequently encountered lesions in this site that have this sort of myxoid-associated stroma or myxoid features. This tumor, in contrast, will be keratin positive, and so it can sometimes look like carcinoma, but it's also brachyury positive, which is considered the diagnostic, sine qua non of the lesion. Now, these lesions, of course, can be locally aggressive and can recur if incompletely excised. Don't usually metastasize, but can have a locally aggressive component because they can be quite persistent and a challenge to resect because of the geography where they are. So I've got another slide of this case, and I think we'll just take a look at that here. Well, actually, different case, a slightly different architecture and pattern. You can see that it's somewhat lobulated. This is less associated with the bone and has a little bit more chondroid appearance to it. There's a higher degree of atypia in this particular slide. Which is important to recognize that you can get cytologic atypia. We don't usually think of them as malignant, but there has recently been proposed a grading schema for chordoma that merits your consideration and understanding. That includes some degree of the extent as well as the cytologic features of these lesions. So I include this just to sort of remind ourselves that there's a spectrum of morphologic changes from the very bland, such as the previous one, to the more worrisome lesions such as this. This is definitely a lesion where you'd be considering other neoplasms as possibilities. And you can see we've got some mitotic activity and so forth here as well. So an interesting part of that differential and the considerations that we need to keep in mind when we are considering chordoma. Now you can see that there are maybe a few more conventional areas like here where we have less atypia and stuff that looks like what we had in that previous case. Very myxoid background, bland cells separated, and of course our characteristic phyzoliferous cytoplasm. So I don't have the grading system right on the tip of my tongue, and it was the sort of thing I don't use often enough that I would definitely refer to the publications to make sure that I was grading appropriately and trying to match that up with the published standards for that. Okay, well, let's shift gears a little bit and move more firmly into the soft tissues. This is a 50-year-old woman who presented with a mass in her back. And she was concerned because this was causing her a little bit of discomfort, made it occasionally she'd roll onto it when she was trying to sleep, and it would bother her a little bit. She had been actually a construction worker, which was somewhat unusual, but was very active and in otherwise generally very good health. So this lesion, which was sort of subscapular, was kind of rubbery and yellowish. Of course, you can see we've got some fatty tissue here. And we might look at this and go, this just looks like, fibrous and fatty tissue. Nothing here to be terribly concerned about. But it is worth remembering that in this location, especially the subscapular area, in people who have been engaged in vigorous physical activity, that there is a distinctive lesion that occurs here that is characterized by, I believe, what you can see here at high magnification. These eosinophilic globules here that are sort of in chains and strands. These are elastic fibers. And if you were to do an elastic tissue stain, these would jump out at you as being really remarkable. But even here on the H&E stain, they're quite characteristic and have this very thickened and somewhat globoid structure, and give this lesion its distinctive name, which is elastofibroma. This is an interesting lesion because it's relatively unique to this location. The subscapular back area seems to be the only area where we find this particular lesion. It's usually in adults and so forth, and not a diagnostic problem usually, other than just being aware that this is a lesion that occurs here. If you're in doubt, if you don't have difficulty seeing these on your stain, these elastic fibers on your stain, or you're wondering if these are elastic fibers, then certainly doing an elastic tissue stain will be illustrative, but not required for diagnosis if you have this kind of an appearance. Now, the differential diagnosis could, of course, include things like fibromatosis or a so-called nuchal fibroma. These cases sometimes actually do have some chromosomal gains of a portion of the X chromosome, which may be why females are a little bit more frequent than males. But it's certainly not a lesion that needs to provoke additional therapy for any reason. But I want to include it here because it does enter into the differential sometimes with other lesions. And so if you get other lesions that occur in or around this area, you may be tempted to think about other lesions. So this is one of those lesions. This is a different case. This is a 45-year-old person who has a mass in the thigh. So different location and so forth, but somewhat similar appearance, a spindle cell, fibrous type of lesion. Here a little more pale, and you can see it has areas of collagenized, almost fascia-like tissue, and a degree of cellularity that's, maybe a little higher than normal fibrous tissue, a little bit more cellular, not particularly, storiform or fascicular per se, but organized in a way that indicates that it's trying to do something. And the cytology of these cells is, quite bland. You can see they have generally entirely euchromatin and occasional nucleoli. There is a little bit of a loose background to this. And the margins, as we look at the margins, they're, here we are up against the muscle and the fascia. It's got a little bit of a boundary here, but maybe not entirely circumscribed in that respect. So the first thing that I would think about with this type of a lesion, a low-grade spindle cell lesion like this, would be fibromatosis. But you also have to consider things like nodular fasciitis, elastofibroma that we just indicated, low-grade fibromyxoid sarcomas possibly, and a variety of other sorts of lesions in that low-grade spindle cell category. So this is a lesion that we then did a beta-catenin stain with. In this circumstance, our beta-catenin stain was negative. It didn't stain satisfactorily in our tissues, but because we were suspicious that this really looked like it was behaving like fibromatosis, we sent the tissue to get a ctNNB1 genetic study to see if the mutation in that gene was present, and indeed it was. So we felt confident then that this was indeed a fibromatosis. This patient did not have, any of the syndromes that are associated with fibromatosis, did not have, familial polyposis or other APC gene anomalies. So this appeared to be a de novo lesion. Now, the important thing about this diagnosis and getting it right is that you're not always going to have a resection specimen like this. And in fact, increasingly, we're asked to make this diagnosis on needle biopsies or smaller fragments of this lesion, because in many circumstances, this is no longer a surgical disease. It can be treated medically with a variety of possible agents. There are some newer gamma secretase inhibitors that have been shown to have remarkable efficacy with this lesion. And so that becomes a consideration as you're looking at needle core biopsies, rather than, as you can see here, a rather radical resection that included muscle and so forth. Now, these can occur in a variety of locations. They usually do not have any giant cells or anything like that. They're quite uniform cytologically. Intra-abdominally, that's probably more frequently seen with the APC gene or familial polyposis patients, whereas, postpartum or something like that kind of lesion, more commonly seen in the abdominal wall or elsewhere, sort of thing. And these lesions will be negative with STAT6, which would, rule out solitary fibrous tumor. They're negative with MUC4, not going to give you the low-grade fibromyxoid sarcoma. They're not a GI stromal tumor, negative with DOG1 or CD117 and CD34 as well. So the beta-catenin stain is very useful, but if it's negative, because it's only positive in about 75% of these cases, it may be worth doing the molecular genetic testing to establish the diagnosis, particularly if that can help you to avoid surgery. Okay, well, another lesion that's kind of in the differential is this lesion. This was a 60-year-old who developed a mass lesion in the neck. And so, we see some degree of circumscription here, sort of right on the fascia, and here abutting some of the skeletal muscle. So it was getting quite large, and so it led to resection rather than biopsy. And as you can see here, we've got some collagenized tissue and a lot of sort of spindly cells in the background. As we look at this, we can see there's kind of a lot of this collagenized tissue, some delicate vessels. And not much in the way of atypia. So again, our differential is kind of a low-grade spindle cell lesion. And it has some degree of maybe zonation, kind of like that myositis ossificans lesion. In areas down here, it's quite myxoid. So it harkens back to that chondromyxoid fibroma. I can look around. I think there's a number of mitotic figures in this lesion as well. This kind of an area here is what is sort of more classically defined as sort of the tissue culture appearance of these lesions. And as I mentioned, they can be quite mitotically active. Well, I'll let you come back and search this on your own time, but I believe there are mitoses that can be identified in this lesion. When it comes into focus, it's not coming into focus quite as well as I'd hoped. So this is an example of nodular fasciitis, which interestingly is another USP6 rearrangement lesion. And you can see that in this circumstance, we're not getting ossification, but we are getting this very dense collagenization, again, towards the periphery. So there is this degree of zonation that can occur with these lesions. And these, again, can be sometimes associated with some sort of a traumatic incident that provokes them in some way. These are usually subcutaneous rather than a deep soft tissue, so that can be helpful in excluding things like fibromatosis, which tends to be a little bit more deep-seated. And there is a natural history, so sometimes these will resolve spontaneously if the surgeon doesn't get there in time. So that's kind of a nice feature. But this, I think, nicely demonstrated this zonation with the central, more immature area, and then the peripheral, collagenizing, more inflammatory process. Okay, well, we may not get through all of our cases, but I'd like to go through this next case as well, because this is also in the differential of these kind of low-grade spindle cell lesions. This was a lesion, intrathoracic lesion, somewhat pedunculated lesion, producing a chest mass, and there was concern for malignancy that led to this being removed. And as you can see, we have a lot of vascular spaces. They're very dilated here, and sort of ectatic. Some people sometimes refer to them as sort of staghorn. I don't see these as being angulated in quite that fashion, but they're certainly a very prominent feature. And then in areas here, you see how it becomes somewhat collagenized with just the vessels remaining. So this is an appearance that sometimes you can see in these lesions if you just get a biopsy or if you get the periphery of them sometimes, because sometimes these vessels will sort of deposit collagen or fibrin, which may become collagenous, and the spindle cells, the stromal cells would become less frequent as you move towards those areas. So this is a solitary fibrous tumor. I can still recall the very first one of these cases, which I encountered as a trainee, which was coming off of the mediastinum and was confused to be either a thymoma or some other sort of lung cancer being involved, but turned out to be this solitary fibrous tumor, which at that time was a so-called fibrous mesothelioma. It had a lot of ropey collagen in it, as well as these cellular kinds of areas. And now we use STAT6 as a very specific and diagnostic immunomarker. STAT6 is a suitable immunohistochemical marker for the fusion gene that involves STAT6 and NAB2, which is characteristic of solitary fibrous tumors. These tend to be usually deep-seated and really in virtually any area of the body. I mean, various people have built their careers on reporting solitary fibrous tumors in all sorts of new locations. And I will confess to being one of them, having reported some solitary fibrous tumors from the liver and pancreas in an earlier phase in my career. But it's an interesting lesion and something that you need to be aware of no matter what area of the body you practice in. Now, these are usually benign or very low-grade lesions, but occasional metastases do occur. And in fact, this is the slide from one of those, a section removed from the bone, which again shows this prominent sort of thin-walled, ectatic, hemangiopericytoma-like vascular pattern with these, fairly bland but stellate spindle cells. And this was a patient who had a known primary tumor, and therefore detecting a recurrence in a distant location away from the primary tumor was sufficient to establish it as malignant. However, you'll note here that the cytology is not overwhelmingly anaplastic or particularly high grade. There are a few mitoses here, as you note here. But that's why this is a lesion that's considered a low-grade malignancy rather than a benign tumor. Okay, well, let's go for one more case. We have enough time for one more case. Let's see. And then we'll take time for questions. So this is another lesion that figures into the differential of these lesions. This is a 25-year-old who had a subcutaneous mass in the upper arm. It had been present for quite some time and seemed to be very slowly growing, but not overly concerning, but eventually got to the point where, as you can see, it's several centimeters and the patient wanted to have it removed. Now, at low magnification, you might say, well, this looks a lot like that solitary fibrous tumor that we just looked at. And I think it does. It has dilated vessels. It has sort of a stellate stroma. It has a little bit of collagenization at the periphery and so forth. And so what's distinctive here? Well, the distinction is that this is a lesion that doesn't stain with STAT6. So it's not a solitary fibrous tumor. And in fact, this is a tumor which marks with actins, smooth muscle actin, muscle-specific actin, but does not react with desmin. So this is not a smooth muscle tumor. This is an actin-producing lesion that has a very prominent vasculature that is called a myopericytoma. It's quite unusual. It's usually present in the skin and subcutaneous tissues, most frequently in the kind of the extremities, head and neck areas, and a little bit on the trunk. As you can see, sometimes the vessels develop areas of thromboses and so forth, and so you can get this kind of backdrop of organizing thrombus as well as the primary lesion. So the differential diagnosis for this includes the same things that we've been looking at, solitary fibrous tumor, but might also include things like a glomus tumor, glomangioma, and maybe an angioliomyoma. But the negative desmin staining helps to exclude that possibility. So those are the cases that I prepared to share with you. There are a few more slides that I posted. We probably use those for a subsequent conference, because I think we've hit the hour here at this point. So if any of you have any questions, feel free to type those in the chat. Or if you're viewing this later on, feel free to email me with your questions or comments about these lesions. I hope this has been a useful sort of examination of some of the differential diagnostic considerations that we see in some of these locations. Thank you for joining me. It's been a small crowd, but we wish you a very Merry Christmas, a very Happy New Year, and look forward to getting together again in the new year on a regular time. And we'll have a guest professor to share some interesting cases in January. So look forward to seeing you then. Bye-bye.